Hello, my name is Arlene Gorelick, and I'm the president of the Epilepsy Foundation of Michigan. I would like to introduce you to a presentation from our recent Wellness in Epilepsy conference entitled Learning with Epilepsy, Overcoming Cognitive Barriers to School Success. We're fortunate to have 4 distinguished panelists with us here today. Dr. Michael Wolff is a clinical neuropsychologist at Behavioral Resources and the Institute for Neuropsychological Services in Grand Rapids. He provides a variety of assessments for child and adolescent medical and congenital conditions, including complex developmental issues acquired through brain injury, learning disabilities, attention deficit disorder, personality issues, and autistic spectrum disorders. Dr. Daniel Arndt is the director of the Pediatric Epilepsy Program at the Helen DeVos Children's Hospital in Grand Rapids. His research and clinical interests include pediatric epilepsy and post-traumatic epilepsy. Dr. Mira Agrawal works as an internist at Integrated Health Associates. Her practice focuses on wellness and preventive health care. She's a mother of 2 children. Her son was diagnosed with epilepsy 5 years ago at the age of 13. It has been a very difficult and insightful journey for the whole family. Dee Youker is from Holland and the mother of 2. Her younger child, Gillian, who's 13, was diagnosed with epilepsy at age 8 and is a former winning kid. In addition, Dee's husband, Dee Youker, is on the Epilepsy Foundation board. We hope you find the information useful, and please remember that the Epilepsy Foundation of Michigan is here for you. This session was sponsored by Children's Hospital of Michigan.
My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and I'll be moderating this panel discussion, which is sponsored by Children's Hospital of Michigan and is entitled Learning with Epilepsy, Overcoming Cognitive Barriers to School Success. We're very fortunate to have with us 4 panelists who will be sharing their perspectives on this complex topic. So we have, I guess we'll start here, have it in different order. We have Dee Youker, who is from Holland, Michigan, and is a stay-at-home mother of 2 daughters, Rachel, who's 17, and Gillian, who's 13. And Gillian was diagnosed with epilepsy at age 8 and is a former winning kid award winner for Epilepsy Foundation of Michigan. And in addition, Dee's husband, Brett, sits on the board of Epilepsy Foundation of Michigan. So welcome. And then we have Dr. Michael Wolff, who's a clinical neuropsychologist at Behavioral Resource and Institute for Neuropsychological Services, or BRAINS for short. And that's in Grand Rapids, and he provides a variety of assessments for child and adolescent medical and congenital conditions, including complex developmental issues, acquired brain injury, learning disabilities, attention deficit disorder, personality issues, and autistic spectrum disorders. So welcome, Dr. Wolff. And Dr. Daniel Arndt is director of the Pediatric Epilepsy Program at Helen DeVos Children's Hospital in Grand Rapids. His research and clinical interests include pediatric epilepsy and post-traumatic epilepsy. So welcome, Dr. Arndt. And then lastly, Dr. Mira Agrawal works as an internist at Integrated Health Associates, and her practice focuses on wellness and preventive health care. And she's also the mother of 2 children, the older of which was diagnosed with epilepsy at age 13, which was 5 years ago now. And it's been a very difficult and insightful journey for the whole family and has impacted her life both professionally and personally. So welcome, Dr. Agrawal. So we have a relatively small group here, so I think if people have questions at any point or anything that you want to add, we'll keep it a little more informal here. So just raise your hand, and Cindy in the back will come with the microphone, and you can share your thoughts or your questions. So first, if we can have everyone just give a brief overview of your experience with epilepsy and the associated cognitive effects. And then what you've seen is the greatest challenge in promoting school success.
Can everyone hear me okay? Is this close enough? Is that all right? Can you guys hear me? Thank you so much. I'm honored to be here, and I'm excited to share my experience with everyone. As Russ mentioned, my daughter was 8 when she was diagnosed. That was in 2007. However, before that time, I knew there was something special about Gillian. I'd always tell my family and friends there was a missing link that I couldn't put my finger on. We had her evaluated for hearing loss. She worked through vision therapy. She was developmentally delayed with most childhood milestones, and she continued to struggle academically. So when we were finally given her diagnosis, it started to answer some questions, and we began to connect the dots. Up until this point, our biggest challenge has been finding the right kind of support for our daughter. By support, I mean not only modified classes and schedules, but understanding exactly what approach and techniques will help her best learn, and then communicating that to her individual teachers and administrators. From the initial diagnosis of epilepsy to the neuropsychological exam and then into the classroom, finding the appropriate strategies can be difficult. However, communication is the key. I feel it is vital to work with the schools to learn what resources are available for our children and getting the proper support we need. Thank you.
Okay, Dr. Wolff?
Well, I think with epilepsy, it's one of the more common medical reasons that individuals come for a neuropsychological evaluation. There's lots of times the need to differentiate what is possibly related to epilepsy versus what's a non-epileptic attack or other conditions. And so sometimes families haven't yet had a thorough medical evaluation, and they're still trying to figure out what the risks are for their child and what might be contributing to their weaknesses. So the role of neuropsychology is to work alongside the medical professionals and to collaborate care, and my job in particular is to understand those functional components. How does it affect memory and attention and language and learning abilities and memory? All those types of things that are important for a child to be able to be successful in life. And so when we're working with the schools, a lot of times schools will focus in on the ideas of, do they have a math disorder, a writing disorder, or maybe an attention problem. But they may overlook some of the testing for memory or decision-making issues that can also be coinciding with epileptic or abnormal brain response. And so as a neuropsychologist, when we're working with the schools, we're trying to look a little bit outside the boxes that the schools are typically going to be considering, and then trying to figure out how we can work accommodations into that classroom to help not only with general learning, but also their functional life progression, so that we don't possibly spur more epileptic attacks by stress or other things like that, as well as get them to qualify for individualized education supports, or what's known as the 504 plans for remediation or accommodations just a little bit less stringent than the IEP. So that's our role as the neuropsychologist, and how we try to work back and forth with the school and the medical professionals, kind of in a go-between position.
Dr. Arndt?
Yeah. So, yeah, along those lines, I think for practitioners, clearly one of the most challenging things about cognitive and behavioral profiles in epilepsy is that they're really heterogeneous in nature, multifactorial, many different factors go into that. And so clearly what's challenging for us in clinic is being able to prognosticate or predict how the child's going to do once a seizure starts happening or epilepsy is diagnosed over the next several years. And, you know, fortunately, the majority of children are going to do well cognitively or behaviorally when they're diagnosed with epilepsy. But over time, you know, it often when we first see the child in clinic, one of the biggest concerns for parents is, you know, how is the seizure or epilepsy going to change my child? And often because there's still a lot of negative stereotypes associated with epilepsy, which have improved over time. But initially at that first visit, there's still this fear that the child is going to be lost. And, you know, it's important to know now that over time we're doing much better with these children. We've made a lot of advancements in diagnosis and treatment, and most children typically do well. Where children fit in like their inner quartile range for these, you know, cognitive and behavioral assessments and performance over time is sometimes difficult to predict, but oftentimes we're not looking at a child just slipping off the slope of all these scores. And so I think that's an important point to make. And then also, really, we rely a lot upon neuropsychology specialists as well as testing right now to kind of really see what weaknesses and strengths are in children that are diagnosed with epilepsy. And so I think that that can be a critical, you know, relationship that's just going to grow with time for us. So, you know, I think that the fact that it's so heterogeneous in nature, you know, these profiles for cognition and behavior in epilepsy, that's one of the most challenging things. And that's clearly one of the biggest things that we'll focus on in the first 2 or 3 visits through, you know, being diagnosed with epilepsy. And so it's just one of the big points that parents bring up constantly. So,
right. Dr. Agrawal?
So I have a son who's currently 18, and I'm not sure where he fits in the whole spectrum, but as a small child, he was always extremely bright, you know, started reading by the age of 2, and so we had this child who was, you know, what you would consider like a gifted or talented child, and then at the age of 13, he developed his first seizure. It came completely unexpected. There's no family history, and it obviously changed our world a lot, you know, and even with myself and my husband being physicians, it's a very hard thing to accept. You think, okay, it only happened once, you know, this can't possibly happen again. You know, you review everybody's family history and there's like nothing there. And anyway, he was started on medications and he was doing okay. So this was just at the cusp of his start of high school. So I had a child, unlike you, where we had, it was a huge learning process where we went from having the occasional seizure, like maybe once or twice a year, and then of all times, it was his junior year in high school, just at the beginning of his junior year, which as you all know is critical in your, you know, learning phase and planning ahead for college, where he had a flurry of uncontrolled seizures. You know, for a kid who's always been very committed to taking his medications on time, and we were on top of things enough to make sure he got enough sleep and everything. And it was a very, very difficult journey for me that year because obviously we had access to great doctors everywhere, and I do have to say that as a physician myself, I learned a lot about how we as doctors fall short for our patients and especially their families. There was a tremendous amount of focus of, oh, don't worry, he's fine, look, his seizures are under control. Well, nobody was very interested in the fact that my now 16-year-old was falling asleep in class. He could barely stay awake. You know, he had gone from being a stellar math student to now scraping through, and he's trying to fit in. He wants to socialize. He can't drive. He's the only kid in his class who can't drive. You know, he also happens to be a swimmer. And it was a tremendous struggle for me. On the one hand, I was trying to find out from the medical perspective, what can we do? And we went to 3 different institutions, you know, to try and figure this all out. But there was this parallel side, which in a way was far more important to him and to us, to allow him to fit in, to belong, and to actually be able to function as a teenager, you know, to be able to do that. And it was, my kids go to a private school in Ann Arbor, which prides itself on their ability to kind of understand and communicate. And I was really, really disappointed initially when my son had a seizure on the soccer field. He loves sports, and he had a seizure on the soccer field. He managed to hit his head on the only metal bench within like 100 yards. He was bleeding profusely, you know, he was unconscious. Every single like sports team was out there that afternoon. And so anyway, they called EMS and everybody, and then they obviously called me. I came rushing down and, you know, took him home since I was able to evaluate him and I kind of knew what was going on. And I have to say I was so disappointed because I did not get a single follow-up phone call or email from a single staff member from the school. And here we had, and I was just so appalled, I couldn't understand this at all. And when I talked to some other people, they said, well, you know, these institutions are so worried about getting sued and, you know, and so anyway, and so this was the beginning of his very, very difficult year. He was mortified and embarrassed that his friends had seen him like this, you know, even though they knew that he had epilepsy, because I've been very, very active in trying to encourage him to say, you know, this is okay, this is an illness, it's a medical health issue like anything else, and if you want freedom to do things, you have to tell your friends, they have to recognize this, they have to understand this. And so then began my very uphill battle with the school to make them realize that they actually didn't know as much as they thought they did. Again, it's, private school, and they prided themselves on, oh, we know everything, and we're so good at communication and emails and everything else. And that was the point that I contacted Russ, and I wanted somebody to come in and teach the teachers about, what this all means, how it impacts kids, and, being seizure safe and everything. It took months. By January, my son, who is a swimmer, who, of course, insisted on not giving up the sport, had a seizure in the water. So you can imagine what that phone call was like for me. So anyway, so I went to get him, and he was okay. And this was kind of like the silver lining of the whole thing, because what had happened was that, that previous fall, when he had that injury on the soccer field, where he had been so mortified that everybody had seen him, it was the brother of one of the other kids on the soccer team who was swimming right behind him. And he remembered his brother describing what had happened to my son. And so as my son went down in the water, he immediately recognized what was happening and went right in after him and pulled him right out. So, and it was kind of a difficult but good learning experience for my son to say, the more people who know, the safer it is. And then just to kind of give you an idea of, like, again, the school where, and this is my son who was doing chemistry and physics and, still planning ahead for college. And right the day after this huge trauma in the water, he had hit his head at the bottom of the pool. He had a chemistry lab, and his teacher put him in charge of, whichever experiment, and she was furious that he could not do it correctly. So I went in to talk to her, and this is a very small school. She knew exactly what had happened to him. And, I, as an internist, speak to people every day of the week, and this woman reduced me to tears. She was so not understanding, and she was highly critical, and I tried to communicate with her what was happening and how could she expect such chemical precision, like less than 24 hours after this event had happened, And so then I was very determined. I was like, I don't care what it takes, but I'm going to have the Epilepsy Foundation come in and teach all of you and talk to you. And it took a tremendous amount of time and effort. And the funniest thing of it all was that the students were actually far more supportive and understanding and helpful than the teachers were. And so it took a while to kind of get through to them, and to explain to them. And Russ did come out and teach, all of the staff. And I think they were very grateful and very understanding. My son was mortified. He was furious with me that there were posters up about epilepsy. And, he's 16. He's just like, what are you doing to my life? You want to ruin my world. And so I've had to kind of balance this, But I do have to say times have changed tremendously, because with all the social stigma and everything, I was very, very proud that year because, like, the kids on the swim team, there were two or three, my son is a big kid. He's like 6'2", And there were several of the kids who pulled him out of the water. And the girl who helped, take care of my son as he seized was his prom date that year. So I thought that was so lovely that the children really, they're so okay with it. And it took me a long time to tell the adults this. I said, look, you can learn from the kids. You don't need to be afraid of this, and you don't need to, pretend like it's not happening. You're not helping the situation here. And so there was a fair amount of progress, but then again, because of his age, there's a lot of things that happen with epilepsy, with the short-term memory, the distractibility, which, that's how teenagers behave. And so again, I did find that as much as they were understanding, and we had a phenomenal school counselor. She was a godsend. She really, really understood what was happening. But, and we came up with like a study plan for him and everything. And they really did get on board. The staff really did get on board, but I found that even though they understood and they mostly got it, if I ever lapsed in reminding them that, you know what, he doesn't remember to remember. He forgets. This short-term memory thing, he's not just ignoring you. And so all I can say is that it's truly a work in progress, you know. But, you know, just to kind of empower your children to let their friends know and let them, you know, understand what's going on out there so that they can actually lead full lives, because for them, that's the most important thing.
Right, thanks. And you raised a point that often is a common problem in schools is that the teachers and educators may be more familiar with conditions that are fairly stable in terms of cognitive performance, whereas epilepsy can wax and wane based on seizure frequency and a number of other factors. And so someone who's doing really well for a long time and then suddenly has a problem, they just attribute that to motivational problems or, well, you should be able to do this, you did this before. So like you said, you have to be a constant advocate for your child. Dr. Wolff and Dr. Arndt, if you can talk a little bit about what are some of the specific cognitive difficulties that are most often experienced by children with epilepsy, the types of difficulties?
Well, I could start that talk, and then Dr. Wolff can follow it up. But I think one of the big things is clearly attention. The difficulty is that there can be an underlying etiology for the epilepsy that could be contributing to some of these processes, but then sometimes the seizure factors, the seizures or the medications or other seizure-related factors can be contributing toward it. And I think one of the big things is attention, but and sometimes even attention and perception problems can even predate the epilepsy starting, but then once you're being treated and seizures are occurring, then attention can be a bigger issue. And then sometimes, you know, based on how the child's doing, their language or comprehension and other factors come into play. And it really kind of depends on how the epilepsy and the underlying process are going as to how the child's doing. The majority of children do pretty well. But the children that have troubles, you know, if there are frequent seizures and there are additional medications coming in, they can really affect like the language and the attention and the concentration. And sometimes it's very tricky to tease out what's what. So let's take a break there.
Yeah, and I'm pretty sure our parents can give us a hands-on example of how this affects their children too. Coming to the attention, one of the things that a lot of times we get asked by the schools in particular is they'll say, well, it seems like the child's able to pay attention as long as they're not being distracted or bothered by things. And in some cases with epilepsy, that's going to be very true. There's many different types of attention, and one of them is simple attention, whereas if you're just working on a piece of paper and you don't have to worry about bells going off and a test and the other pressures, a lot of kids can still do that. But the divided attention, whereas if there is distractions, it can be problematic. Or the working memory is that little blip that was talked about down here, where if all of a sudden the event happens, within 30 seconds or less, it just all of a sudden an event occurs. If you were giving them directions during that time, or if they were in the middle of reading a paragraph, they might all of a sudden lose not only the memory, but what they're supposed to be doing during that moment. And so it looked to them now like they're being completely inattentive, where in fact, it was probably just a working memory issue, and that's probably one of the smaller, quicker blurps that can happen from an epileptic event. The memory is probably the second most common thing that we see. A lot of these children can't do complex memory. If we give them a list of items and repeat it and we repeat it and we repeat it and we do it repetitively, they certainly can learn. But if we give them a whole new concept all at once without trying to put some sort of understanding to it, they'll come away from that going, okay, I just listened to you for half an hour, but I'm not exactly sure what you taught me. So trying to take in too much all at one point in time is also a problem that we'll commonly see. And then the last thing, that's probably one of the more common things that brains rules out, but is debatable in neuropsychology, are things called processing disorders. And I know we heard over here the idea of, do they have an auditory issue? We took them to an audiologist because we weren't sure if they were hearing, and a lot of families will say they take them to an eye doctor too because they're not sure if they're seeing correctly. And a lot of times those sensory organs can be very intact and then be fine, but the information relay from the sensory organ through the brain and how it gets processed in the association cortices to finally put output back into the world, there can be a lot that happens, and there can be little blocks that start to develop. And so even though the functional systems of hearing, sight, sound, smell, and those things are technically okay, it doesn't mean they're being processed normally throughout the brain parenchyma. And so a lot of times we'll have families saying, but they can do this, why can't they do that? even though they're very similar types of tasks, they are relayed a little bit differently. And our science is definitely not perfect by any means at all, but our job is to try to figure out how those processing and how that information gets routed through the brain and what the output looks like as well, so that we can more specifically address that. So the parents probably have some pretty good examples of how functionally epilepsy looks in their kids too. So,
And just as a quick follow-up to that, you mentioned a lot of different cognitive functions there. Are many of those functions assessed on a standard school assessment that you would get with a school psychologist, or are those the types of things where you would really need to see a neuropsychologist to get at that level of detail?
that's a good question. You will typically need to go to a neuropsychologist to get that level of detail. Schools and school psychologists are starting to branch into the concept of neuropsychology, and it's called school neuropsychology. But realistically, their focus is primarily on how are they learning material, so reading, writing, spelling, math, and the academic contents that are considered to be impairing for the school. They're not yet trained in a lot of these other subsystems, nor in how complex medical factors can relate to the way their test results look. And so typically you will be garnered going outside, but after that you don't have to come back to a neuropsychologist usually that often. About once a year, but we can work the rest of the year with the school psychologists, with the families, and everyone else to bring that data to life. So typically school psychs are very cooperative with us once we have that bigger picture.
Okay, great. And in terms of the parents, what specific cognitive challenges have your children struggled with most?
Personally, everything that the doctors have mentioned, Gillian has probably struggled with in some form. We've struggled with the memory, we've struggled with the comprehension. In terms of math, we taking one math and presenting it in another form, is she struggles with very much. Organizational in her writing is a big issue. That's huge. Understanding written directions, she has a real hard time. Her teachers have to read her directions to her for her to understand that. Studying effectively is a huge problem for her. We'll address that with later in the program. She struggles at basic grade levels. She's about a grade and a half to 2 grade levels behind right now. And then her working memory is, I was told when she had her neuropsych exam that is a big issue for her as well.
Okay. Dr. Agrawal?
I would completely agree with what you said. That was pretty much exactly the experience we had. And, you know, good or bad, I think that our experience was different because, you know, I had a son who was at the upper end of the spectrum of school. And so he was a kid who, you know, is exceptionally bright at math, and, you know, things came very easily to him. And then now we have all those things that you just described with, you know, short-term memory loss, lack of organization, forgetting what he's completed and what he hasn't, you know, getting distracted. Writing as well has been a huge problem for him also. So his grades have fallen, and again, this is where we've struggled, where he now gets like B's and C's, which in the vast majority of the world out there, they're just like, well, that's fine, what are you worried about? And unfortunately, I've heard this from like the physician end as well as, you know, the school end, where it's just like, well, I want my child to be able to perform maximally, you know, I know what his capacity is. And, but yeah, so it's just, and the one hurdle, I think that the neuropsych testing was probably one of the most helpful things we ever had done. He's had like a total of 3 now over the years. But I will say again, I mean, it's expensive and it's not covered by medical insurance, you know. And again, as a physician myself, you know, with patients in my practice who have epilepsy or even have family members with epilepsy, I try to encourage them, you know, based on my own experiences, but that there's a huge, I mean, it's thousands of dollars, you know, it's very, very expensive. I believe it's worth every penny. I mean, it helped my son kind of regain a lot of his self-confidence because he kept beating himself up. He's like, oh my gosh, how could I possibly get this grade on a test, you know? And when he recognized what his deficits were, I mean, until you know what the problem is, you can't really approach it head on to fix it.
And are there what payment options are there for neuropsychological evaluations if you can't afford the $1,000, are there any other options in terms of getting that paid for?
Sure. And Dr. Arndt and I were just talking about this as we came up here today. We've been fortunately blessed at Brains that if we have a medical etiology, most of the major insurance panels in our community are working with us to cover these for families. And so we've been successful that way, but it is important for us to work with the physicians because they have to kind of give us the codes that they're using at the clinical side of it so we can field those in. And we do use a medical code, code 96118, which comes under the medical health benefit for a neuropsychologist to be able to work with that. But if the physician that we're working with doesn't give us a medical etiology, then it's very, very challenging to get neuropsychology covered. Brains, in recognizing that, has developed a nonprofit foundation where we do use predoctoral interns, and a lot of hospital models are following this, where families who don't have insurance that can cover it, we do use the Federal Poverty Guidelines sliding fee scale to bring families in for those evaluations. And at this point, it's been operating for 3 years, and 92% of our families are coming in and getting completely free neuropsychological evaluations for their children. But that is a challenging model to follow because you still need to raise the money, and so you're constantly fighting between how many hours can I do in clinical service versus having to get out there and raise money to be able to support the stipend costs for these doctoral students and then their supervision and oversight. But we are trying to be flexible. I think a lot more neuropsychologists are recognizing that insurance are limiting our practices more and more, unfortunately, and as a result of that, we need to align with physicians to help us help families, and that's worked well.
Yeah, I guess just to add to that too, more so over the past 2 or 3 years, as doctors, I think we know that, or have noticed that the coding has become more and more important. And so when we send out that referral for neuropsychology testing and it comes back rejected by insurance, it becomes more important for us to pay attention to the code that was initially sent out. And sometimes what happens is, you know, a parent or a patient will call in and we'll receive a phone message from one of our nurses, and we turn around and order the testing, and then one of the nurses has put in the code. It may have been an incorrect code or unrelated to whatever the testing would be needed for, and it ends up getting rejected. And down the road, hopefully things are pursued, and we might find out through a peer-to-peer, you know, talk to try and get the neuropsychology testing that it was just the wrong code at the beginning. And so that's important for your children, just to pay attention to the right code has been sent out for it. But yeah, as we were walking up here, I learned that more neuropsychology testing can be approved or covered that I wasn't aware of, you know. And so I think it's changed a lot over the past 2 or 3 years especially.
Okay. I wanted to talk a little bit about some of the key epilepsy-related and treatment-related factors that contribute to cognitive problems in children with epilepsy, looking both at modifiable factors, and like side effects, for instance, and then those that may not be able to be changed and you have to adapt to. So let's start off by talking about some of the modifiable factors that contribute to cognitive difficulties in epilepsy. Anyone?
So, I mean, I think that's a whole hour lecture in itself. And so you can imagine...
Yeah, we'll be on the brief side here.
Yeah, just to touch the surface on everything. But you can imagine in an hour-long initial consultation for a patient with a new diagnosis of epilepsy, we're probably not even going to cover that. I always try to make a point to save 5 or 10 minutes and hurry up through the other things to try and approach those things, because those tend to be the most important things to families. But when you look at what goes into the cognitive and behavioral profile for a child with epilepsy, number one factor tends to be the underlying etiology. Okay, and sometimes through the first several visits, we don't actually have that. Maybe the MRI is not done, maybe, you know, certain testing is not done to actually get that etiology. But on top of that, we know from other IQ and cognitive studies, socioeconomic factors can be important. But those are not typically things that we can modulate or manipulate with medications, you know, in a neurologist's office. But in addition to those two primary things, medications can be a factor. Seizure frequency can be a factor, age of onset for the epilepsy, how long it's been going on. These can all be factors, and there's many others. But I think our important job is just to make sure that when we see a patient with epilepsy and we're going to start treating them, making sure that we selected the right agent for that epilepsy that has the least chance of having any cognitive or developmental side effects. And it's more important for children, I think, personally, than it is for adults, because the brain is still growing. And all those processes are going to be, we say prune, all the neurons are going to be pruning themselves or organizing into certain pathways for possibly up to 10 or 15 years. You know, the majority is through the first several years of life, but just very important for us to try and choose a medication that's not going to interrupt that or cause cognitive slowing. And fortunately, some of our newer agents, you know, the first 2 or 3, they only have, you know, less than 30% chances of causing some cognitive slowing or those issues. So really critical for us in the first several visits to make sure that we haven't started up a medication too quickly or chosen the wrong agent for a patient that's going to be not controlling seizures or causing worsening cognitive slowing. So I think that's a start.
Right. Dr. Wolff, did you have anything?
I was going to say, I think one of the biggest things in a broad brush sweep here, environmental management is just as important as managing those medications. In order for us as neuropsychs and the medical professionals, neurology, and a primary health physician and families, is to know what might be contributing to the seizures. And the more chaos there is in an environment, the harder it is for us to make inference. And so if they're still in an extremely challenging school system and on a school schedule, and if, you know, the families are running all over the place and we don't have but 5 or 10 minutes to maybe grab food here or there, a lot of those stress-related factors can increase the potential frequency of epileptic events. So one of the things that we'll commonly do for families is try to slow the systems down. Let's get predictability in the environment. Let's try to at least be able to garner some more understanding of when are the seizures happening, under what occurrences are they happening, so that we can relay that information back and forth. Is it a med issue? Is it an environmental issue? In understanding those seizure events. So that's a broad brushstroke, I know, but it covers family and home, and, you know, how often are you running around? What types of social activities are they doing? How much pressure are they experiencing from social stigma, as well as how many medical appointments do they have? A lot of our younger children in particular, the more they go see these doctors, the more they start to get worried themselves. And the more there is an iatrogenic effect from, you know, I must be really bad because I'm seeing doctors all the time. And lo and behold, the symptoms can get really bad. But when we start to slow it down, saying, you know, you're going to be fine, just let us keep working with you and try to provide a sense of stability and encouragement, lo and behold, we can get symptom management sometimes by just that confidence that we're going to care for you and your family knows what's going on. We're not going to lose you here. So that environment's very important for a modifiable factor.
Right. And you've used the term epileptic events a few times, and that, I'm assuming that can refer to both seizures, which can disrupt cognitive function, but also those spikes, those what are called interictal epileptiform discharges. Can you talk a little bit about, there's some debate as to the level of impact that they have on cognitive function, but can you talk about that a little bit? Either, yeah.
Well, that's a very hot topic
Yeah.
Of research, and it has been for a long time because we're learning a lot. I think that there's clear cases where the interictal EEG, we say, or the between seizure EEG, just like that you would see on a routine EEG, when there's spikes of electricity, we know that it can be clearly affecting a patient. One of the easiest clinical scenarios to point out like that is when a patient goes to sleep and the EEG continuously has spikes, and it meets definite criteria for one of the syndromes on EEG that we can diagnose at night, and we can use some of our medications to try and improve, and oftentimes we can see an improvement in cognitive status. That's clear and definite. And when you have infrequent spikes, we're not so sure that those are overall changing the cognitive status of the patient. There's a bunch of children in the middle right now that are people, that adults too, that have a frequent amount of spikes, not, you know, on either side of the spectrum, that we're wondering how often those actually influence cognitive behavioral status. So there's a lot of papers either way, so that will always be a controversial issue
Right.
until we get some more research in the next 10 years, I think.
Right. Okay. Let's see. So let's talk, we talked a little bit about the modifiable factors. For those that can't be changed, like the underlying etiology that you mentioned, or you know, several other factors, what are some of the best ways to adapt to those and to compensate for memory problems and compensate for cognitive deficits? And all panelists, I'd like your input on that.
I think if it's okay, I don't mean to talk again, but I could just start this by saying I
Okay.
think about 6 to 12 months into treatment for my patients, that's where our clinic visits have slowed down a little bit in terms of you know, what is epilepsy, what treatments are we using? Ideally, patients are a little bit more stable in their regimen, and then the questions start coming out. Yeah, but he's still not doing well in school, and the school's not doing anything. And we've done, I think we've done some cognitive tests with maybe an IEP plan or a 504 plan or something like that, and they pointed us in a direction, but what can we do? And then it's easy for me to say, let's do neuropsychology testing and figure out exactly what the problem is and then go from there. Yeah.
Well, my experience, again, I think it's very important that, like you said, with, you know, finding the problem, but I think like when you talk about etiology, I really found in my experience as I talked to different epileptologists, and I think, you know, it's such a, like not only is epilepsy itself such a huge spectrum of disorders, but it also, you have so much more to look at where, like your daughter, Gillian, like she's a small child where you have a lot of control over her environment. My son was at the beginning of his teen years when he was diagnosed with epilepsy. And I think it really behooves you to find the right neurologist, the right specialist who understands where your child is at in their world. Because I did have several experiences where the focus was just like, well, see, he's not seizing, he's doing great. You know, see, there's no seizures here. And I'm like, my child can't like go out, you know, he can't have fun with his friends, he can't like stay awake enough in class. You know, his biggest, you know, here was my husband and I so worried about, are we going to make it to like next month and next week or whatever, because he was having so many of these seizures. His only interest was, I want to drive and I want to swim, you know. So it's a huge collaborative effort to find the right medications, because he had been on medications that were working, but he was sleeping. He was just constantly asleep, which may not matter if you have like a 2 or 3-year-old child so much as if you have, you know, a child who's now moving on into a very competitive time in his life where, you know, thinking ahead to colleges, and I mean, that was my biggest concern, because I didn't want to I didn't even have the heart to tell him, I'm thinking of just keeping you home, whereas he was just like gung-ho with his whole approach. And part of what I meant by saying, well, I had this very bright child, was just to share that it was a huge learning experience for all of us. You know, I have this family where we have very, very high expectations of ourselves and our children. And to even acknowledge, first of all, for myself, and then to tell him that it's okay, it's all right that you're not excelling, you're doing the best that you can, and to not beat yourself up over it, because that's an added stress, like you just said. And I think it was hard for him to believe that we truly meant that, you know, that you have to kind of find your way. The health piece of it is so much more important. So there are so many pieces to the puzzle, but you have to, I mean, I truly believe that you have to have, you know, we have wonderful doctors now that we have a good relationship with, but you have to have a doctor who truly understands your child, who's very vested in where your child is at in their world, and equally so with the school. And it doesn't have to be all of the teachers, but even if you have 1 or 2, you know, like our school counselor, she was just wonderful for him. And as much as he kind of avoided her and didn't want to be seen with her because, oh my God, people are going to think I'm like weird, you know, but she truly was kind of behind all of that. And then I was the third piece of it. I had to give up a lot of my work. I cut back my hours, and I realized that this was like an important time in his life where I had to kind of help. And you absolutely need to have that whole triangle to make the system work.
Right.
So
the partnerships
Yeah.
with the school, with the health professionals is very important. What other, in terms of like daily cognitive strategies and also assistive technology, and then services and accommodations in the school have you found to be most helpful for children with epilepsy?
Well, I was going to just maybe expand on that a little bit, because you talked about, you know, having your son and going into the school, because that's kind of where, oh, I just turned on. That's kind of where our challenges started,
Yeah.
because from when we started with the neurological psych exam, we got our information, and so when we got that information, we said, okay, what do we do with that information? So when we took it to the school, we said, okay, where do we go from here? What do we do with all that information? How do we teach her? How do we help her learn? What's the best strategy for her? So we have a good school system. Our teachers do understand, and the school is supportive, but we had to know what to do with that. So, Russ, you want to know with what cognitive strategies? What we did was I got a note together and I sent that to all her teachers. And that's what I have to do every single year, because every year she has new teachers. Some are the same, some are different. But I write a note every single year. I said, this is what my daughter struggles with. These are her challenges. And every single year I have to write that out. Her memory issues. She struggles with math. She struggles with comprehension every single time. And in her conference, I have to go in there and we have to set out all her, her modifications and her IEPs and everything. But it's a struggle all the time. But that's what we have to do every single time. How she has to take her tests and where she has to go to take her tests. So that's just something that we have to do.
Some of the other things that we look at for assistive technology, and we started to go there, and I can see her note sheet. The iPads, the iPods, and things like that are really starting to help a lot of our kids. The more we can take out of their minds so that they can actively use their minds in learning and not just remember simple scheduling types of things, and this is true for pediatrics and adults, the easier it is. And in the last years, I had previously recommended the Timex Data Link watch a lot. Unfortunately, they stopped making it now, but you can still find it on eBay. But it was, as an example, it's a watch that you can program in over 400 alarms to. So it syncs with Microsoft Outlook. You plan in a schedule and then you just hit repeat, and then you plug in your watch. And the cool thing about the Timex Data Link watch was that schools wouldn't stop you from having it. They might not let you have an iPad or an iPhone because that's going to be too big of a distraction. But this watch would have 400 alarms in it now. And rather than just sounding an alarm where you'd have to go, what does that mean? It actually would come up with a little text message that you programmed in on your Outlook. So that way they'd have to keep less in their mind and they'd have it kind of autopilot so they could devote attention to learning. We're starting to use SimTrend in our clinic. It's just one of the many examples. But a lot of times we want to know seizure tracking and seizure logs. And we all like our data, but we all hate to analyze it. This is a way that SimTrend's an app that you can use on a computer or anything like that, where you can track your seizure logs, and it automatically, once you hit it on your iPhone or iPad, whatever you want to be using, it pulls that data into our clinic where we can pull it offline, so we can see seizure frequency, occurrence, what was going on during those times. So we get that data in real time versus maybe once a week, once a month, if even, because sometimes we get the data, and I hate to be honest here, but all of a sudden we have all these pages, and who's got time to enter all that data now and to put it into Excel and then to give it to the doctor in a way that makes sense? So SimTrend helps to autopilot that for us, but that's just one example of that. The Livescribe Pen, if you're not familiar with that, I'll let you explain that. Go ahead.
Well, I'm not a real expert on it, but this is the Livescribe Pen, and this is what my daughter Gillian uses for her note-taking, because that's one of the areas that she struggles. And I don't know if anybody's familiar with it or if they've used it before, but this is the pad that you use it to take the notes. And it basically, you just use this pad, and it's just a little computer in here, and you can write all your notes, and then if you forget what you heard in your lecture, you can just tap back on any word in the lecture, and it will read back.
It's an auditory cue.
It records what the lecture is, and it will read it back right to you. And if anybody wants to see it after the presentation, I can show it to you, but it's really amazing, because this is one of the things that she truly struggles with, and it was the biggest challenge, well, one of the biggest challenges that we had, and this is provided by our school, so we're very fortunate because they are about $100 a piece, and so our school has been very generous to give that to my daughter to use for school. So.
And the other neat thing with the Livescribe Pen,
I didn't know.
yeah.
This is our first year using it. So.
Yeah. It's a pen that's been around for a couple of years, and we commonly recommend it too. But the other unique thing that's not mentioned is some of these pens, there's several models of them.
Yeah.
If your student or child learns better by reading what they're learning versus hearing it, you can actually plug it into your computer and it will transcribe what's been said as long as the audio recording is clear enough. So now you can get a transcription of the work as well. And the tapping on the notes is absolutely fantastic. So if they happen to have an event during that time where they all of a sudden, I can't remember what I just happened here. Click it, and you don't have to re-listen to the whole thing. It's auto-specific to that area where you might have missed that note. And so we commonly will recommend that as well. And then the iPad technologies, there's just so many apps and little scheduling strategies. It's becoming kind of a secondary brain for some of these individuals. So I do encourage a lot of those assistive technologies to take the pressure off the brain to learn what it needs to learn and to not have to deal with the mundane as much.
This goes too for all levels, because Gillian's in 8th grade, and this would go all the way up to college level.
Yep.
Yeah.
That's really neat.
Great. Well, I wanted to allow some time for questions or comments from the audience. Does anyone have any questions about anything we've discussed so far? Yes, right here. Cindy's coming around.
Question for Dr. Agrawal. I admire and respect the work you did with the school in terms of education and awareness. I'm a little bit curious, if you're willing to share it, did you see a positive change in the attitude of your son's chemistry teacher as a result?
You know, that's a really good question. It took a long time, but she actually had him removed from the class. That was kind of the discussion we had, and you can imagine he was crushed, you know, and it's very funny now because he's in college doing extremely well in his chemistry course, because he's been seizure-free for a year, and so she avoided me for probably like several months, but the most key part of it was actually, I don't know if I ever said this to you, Russ, but after Russ came out and educated these people who thought they knew everything already, she actually went to the school psychologist afterwards and never directly apologized to me, but did say that she felt very bad about what she had done, and she realized, you know. So I mean, it was okay. I mean, you know, everybody has their own style, and the fact that she couldn't approach me directly was fine. I was just glad that she would not inflict this on another child, you know, at another time.
We had a question in the back there.
Live.
Livescribe.
Yeah, Livescribe.
Livescribe. You can get them at Target.com or Amazon.com or Livescribe.com. They're all on, yeah, Staples online.
Okay. Any other questions? Yep, right up here.
I have a son who's in kindergarten right now, so we're just starting to go into the world where his world is widening with respect to play dates, activities after school, coaches, Sunday school. And I struggle with how to educate those that are caring for him without scaring them. He's well controlled right now, and I just didn't know, as parents of middle schoolers and teenagers, if you have any recommendations on how to do that, how to inform people as much as needed, not over-informed to the point of they're looking at you like a deer in headlights thinking, oh my gosh, your child's a time bomb waiting to go off, and I don't know what to do with this. So I just, you know, we're kind of venturing into that world right now, and any advice that other parents can provide would be really helpful.
You're talking about talking to the parent directly or the children?
Well, it could be, we're at a point where a parent of a friend, so my son goes over for a play date, could be a soccer coach, his Sunday school teacher, really any new environment he's in where I'm not necessarily there. And we've gone through the process with the teachers and the school nurse, educating them, but it goes beyond that in more of the social circles. And as you explained, it did sound like when he had his seizure on the soccer field, there were people that maybe didn't know what to do or didn't handle it the best way, and it's hard to know how to prepare people for that circumstance without, I don't know, how to find the right way to talk about that.
My son was older, but if, you know, I'll just like comment on it, but I think that I've always told him that, you know, the more comfortable you are with the whole situation, the easier it will be for everybody around you. So if you tiptoe around it, then they'll think something's wrong. But if you're very upfront and, you know, you give them other parallels, like, you know, children who have type 1 diabetes pass out and they seize. You know, kids who have bee sting allergies can also have major anaphylactic reactions. And again, that kind of, you know, that's where the difference between the stigma of epilepsy and these non-epilepsy medical issues is. So if you start there and just say this is a chronic illness, just like any of these, And I think that the Epilepsy Foundation is a great resource for, the Seizure Smart information. I mean, I sent my son to France on a school trip on his own, with a group of kids, and a lot of the other parents thought I was like nuts, but I was like, you know what? I mean, I'm okay with this. I had had enough of a conversation with the teachers, the chaperones, and the other students, that I let him go because I want to empower him and make him realize that you can do this. So if you start young, I think with the other parents, if you're okay with it and you just explain it in a very matter-of-fact sort of way, I think they'll be okay with it.
I agree. We've never hidden the fact that she has epilepsy. She's never been shy about it. I totally agree. She's always talked to her friends about it. When she was first diagnosed, she wanted to tell her class about it. She said, I'm going to do show and tell. She said, I'm not going to show, I'll just tell. So, yeah, she's been very open about it, so I completely agree.
Okay. Any other questions or comments? Yep, Dr. Kim?
Dr. Wolff, are there any indications you recommend the neuropsychological testing for any school-age children's?
So just what indications for neuropsychology testing?
Right.
Well, I guess just the extremes are easier. I think if somebody's doing very well and there's no concerns in school and they're seizure-free, that's easy. I don't think that we need neuropsychology testing, but I think if there's any concerns regarding, cognitive or behavioral performance at school, at home, socially, anywhere, I think neuropsychology testing becomes a real indication just to make sure that we have the patient getting the right treatments and therapy or whatever, assistance. So I think that's kind of an open-ended statement. You can get neuropsychology testing for anything, if that's just a start.
I'm obviously a little bit biased because it's my livelihood. But in brief, my bias is always, as soon as you suspect that there's a medical condition or an abnormality, to allow us to set baseline. Because a lot of times we'll get the question ex post facto on, so what's still possibly a residual from the seizure or some type of acquired injury versus what's just the way they normally are. And if I don't have baseline data, I do have some predictive validity on what might be premorbid, but it's very challenging. But if we're catching it as the symptom starts, I can then make predictions on, is it worsening, is it stabilizing, are we starting to see cognitive patterns that are finally starting to hit their plateaus. But at a one-time occurrence only, it's hard for me to do that. So baselining is important, and after that, it might be once a year, it might be once every 3 years. As needed, but that baseline is important.
Okay. We have time for maybe, did you have a follow-up?
Did I get the code right, 96118?
Mm-hmm. Code 96118 is the code used, the medical code used for neuropsychological testing.
Okay, I think we have time for maybe one more question. Yeah, up here.
We have a little guy, he's almost 3, and he just had a psych evals. I know it's not neuro, it's through the school, because he's going into special, education preschool. And she explained that he processes slow. We knew that, we can tell. But I just don't know if there's anything we can do about that, or we should advocate for him in preschool, about that. He's just slow. He's had intractable epilepsy pretty much his whole life since he was 2 days old. So I don't know if you have any suggestions, or even at this age, he should maybe have a neuropsych exam.
Good questions. The research on how to improve cognitive processing speed when it's not related to a medication or the medical etiology itself is fairly sparse at this point in time because we've never figured out how to get the brain to work faster. That said, there are nice models out there with neurofeedback, with a program called CogMed, VisionTherapySolutions.com, CogniFit, Luminosity, SharpBrains.com, and Brains Connection Positive Science are all trying to engage the brain with different game types of activities to speed up the efficiency of activation and work. And so hopefully through some of our computer simulation that are actually working the brain, not just reflexive brain. Most video games are reflexive brain where they really don't do much for the brain at all and can make it worse. But some of these other models are coming out. We're hopeful that they will finally work. But it is hard, and there's not good research out there on how to speed the brain up outside of its anticipated capacity.
Okay. Well, I think we're going to have to wrap things up, but I want to thank all of our panelists for sharing their insights. And we do have a break now, so if people want to come up and ask questions, I'm sure they'd be willing to stay a little bit longer. So thank you very much, everyone, and thank you for attending this session.